Hi guys, my name is Heidi Escobar and I'm the Director of Admissions and MDS here at Bethany. Today I'm going to explain a little bit about the MDS, which stands for Minimum Data Set. At university we have 2 RN MDS coordinators, and at 42nd we have 1 RN MDS coordinator. The MDS is multidisciplinary, meaning that different departments have different sections of the MDS to complete. Social services, activities, therapy, dietary, they all have questions in the MDS to answer. But ultimately the MDS coordinator, which is an RN, has to be the one to complete and sign off the MDS per federal regulations. The MDS drives the care plan for the resident. It drives the survey process for when we have health department visits. It drives our facility quality ratings, as well as it drives reimbursement for the facility. It's a pretty important document. Within the MDS, there are over 600 questions about residents, ranging from diagnoses, cognition, depression, medications, therapy, ADLs, behaviors, pain, you name it, it's on the MDS. In order to code the MDS, there has to be documentation in our medical record to support that coding. The MDS cannot be the first place that you see something documented. There has to be reference to support the MDS in a progress note, in the MAR, in the TAR, POC documentation, etc. So CNA and nurse documentation is super important for that very reason. We have always heard, if you didn't chart it, it didn't happen, and that is most certainly true for the MDS as well. I'm going to highlight some of the key things on the MDS that the MDS coordinators look for in documentation. One thing is oxygen. So if somebody is on oxygen as needed, or PRN, we need to have specific times in the medical record that the oxygen was put on and when the oxygen was taken off. In order to code it on the MDS, the oxygen has to be in place for 2 hours. So having that specific time frame documented in point-to-click care is crucial. Shortness of breath. So the MDS specifically wants to know if the resident is having shortness of breath with exertion, while lying flat, or at rest. So it's important to make sure that you're assessing all of those things and documenting them each separately. You don't need to actually make the resident lie flat to see if they have shortness of breath. If they say, oh no, I never put my bed down because I get short of breath, or I always sleep with my head of bed elevated, that's your cue to chart short of breath while lying flat. ADL documentation is another big one for the MDS. The CNAs mainly do ADL documentation, but they may come to the nurses to ask for help or any clarification. There are 4 ADLs that play a major part of the MDS, which is eating, toileting, transfers, and bed mobility. The codes that we use for ADL documentation are independent, supervision, limited, extensive, and total assist. So independent, self-explanatory, the resident is able to do things on their own completely. Supervision means that you're just providing cues, such as here's your water, take a drink, make sure you swallow before you take another bite. That's supervision. Limited assist means you're providing guiding assistance. So if you're walking with somebody and their hand slips off their walker, you're guiding their hand back to their walker. That's limited assist. Limited means no weight bearing, so no muscle. You're not using any muscle when you're charting limited assist. Extensive assist means that you are using muscle to help the resident complete the task. The resident is still doing something and helping, but you're using muscle to help them as well. So lifting their legs into bed, or lifting their arm into the sleeve to help with dressing. Lifting the actual person with a gait belt to help them walk or transfer. That's extensive assist. And total assist means that the staff member is doing 100% of the task for the resident. So the resident is not doing anything to help at all. The second part of the ADL documentation is coding how much assistance the resident needed from the staff. So there's no setup or help. There's setup assistance only, assist of 1 or assist of 2. Those are pretty self-explanatory. Another thing to code on the MDS, which we look for, is skin integrity. So if a resident, if there's a pressure ulcer, if there's a skin tear, vascular, diabetic ulcer, pretty much anything skin integrity related, there needs to be documentation to support that. If there's a dressing on it, number one, make sure we have an order for that dressing, and number two, make sure we're documenting that that dressing is in place and changed per the order. Obviously, our ultimate goal is to heal any skin concerns, so if you're putting a dressing on day after day after day or week after week and there's no change, make sure that we're getting the provider updated with that, because we can probably get something else in place for that. Medications, so there's certain drug classifications that the MDS wants to know about, which are psychotropic medications, anticoagulants, diuretics, antibiotics, insulin injections. So when the MDS coordinators look at that, they look directly into the MAR and count how many days a person has gotten those medications, so making sure that you are signing off your medications during your med pass is crucial. And then the last thing I want to touch on is respiratory therapy. So if a resident is on nebulizers, the nurse is responsible for doing the respiratory therapy assessments, and then we check oxygen saturations, listen to lungs, check the heart rate, and then document the amount of minutes spent with the resident during the setup, during the assessment, and administration. That all counts. So the nurse needs to stay in eyesight of the resident while they're doing the nebulizer. The documentation in the treatment record is what is used for counting the minutes on the MDS. So one thing to remember is you cannot count cleanup time. You can only count setup, assessment, and the time that during administration when you are with the resident. Should be about 5 to 6 minutes per nebulizer. That's just kind of what it averages out to be. Goal for respiratory therapy is 15 minutes per day. And if you're giving a nebulizer and notice that there's no respiratory assessment prompt in the treatment record, make sure that you enter that via the batch orders. So that is all I have for you today on the MDS. If you have any questions, feel free to contact me, Heidi, or any of the MDS coordinators at either campus.